Good morning, good afternoon, good evening, wherever you are. I am Riza Lingwa, Communications Manager for the Foretia Foundation, welcoming you to this very special webinar hosted by the Catholic Policy Institute of the Foretia Foundation. This webinar is organized within the framework of the Private Health Insurance Project, which is being implemented by the Health Policy and Research Division of the CAFU Policy Institute. Today's panel discussion is organized on the theme, the impact of COVID-19 on healthcare financing in Cameroon. I now have the great honor to present to us today's moderator, who is no other than Dr. Kibu Odek, who is a senior health policy analyst and the coordinator of the CAFU Policy Institute. Dr. Kibu equally holds a master's degree in chemical pathology, as well as a bachelor's degree in biochemistry, all obtained from the University of Boya in Cameroon. Ladies and gentlemen, thank you for joining us, and I wish to remind us to use the chat box to drop in our questions and contributions in the course of this webinar. We will have a question and answer session at the end of the panel discussion to address your various questions and concerns. On that note, I will now hand over the floor to Dr. Kibu to introduce to us today's panelists and to moderate the rest of the panel discussion. Dr. Kibu, you have the floor.
Thank you very much, Riza Linwa, for giving me the opportunity to moderate this session. Ladies and gentlemen, distinguished guests, good morning, good afternoon from wherever you are. It gives me great pleasure to welcome you to today's webinar organized by the Health Policy and Research Division of the CAFU Policy Institute under the project Reducing Barriers to Private Health Insurance Coverage in Cameroon. And thank you all for taking your time out of your busy schedule to join us today. It is important for us to note that the response to COVID-19 pandemic has been a collective movement following the negative impact it has placed and continues to place in economies and systems worldwide. In Cameroon today, we will note, and on other African countries, the COVID-19 pandemic has exposed the structural weaknesses of each country's health system and its economy particularly. So it is very important for us to understand how this pandemic has affected healthcare financing. And in an African system that is considered pluralistic, we will discover that the health system derives its funding from a good number of sources, it's either from the states, from NGO, from faith-based organizations, or from individuals, that's out-of-pocket spending. And it continues to be a primary source of funding amidst households nationwide. And so this leaves us to wonder whether the already existing disastrous expenditure on households to finance healthcare will worsen as a result of the pandemic. It's the reason why we are gathered here today. So we are gathered and with an exciting lineup of panelists who will share their expertise on addressing a range of important issues regarding the impact of COVID-19 on healthcare financing and propose strategies to improve healthcare financing and accountability in order to build a resilient healthcare system. On our panel today, ladies and gentlemen, I am pleased to introduce to you Dr. Gizachu Tesama. Dr. Tesama is a senior fellow at the Curtin University, Australia. He obtained his PhD in 2018 from the University of Adelaide in Australia. And prior to that, was a master's degree in public health from the University of Gondar in Ethiopia. Dr. Tesama has published over 80 high impact journal articles, and he currently leads a program of research focusing on maternal and child health and health services and global health. Thank you, Dr. Tesama, for joining us. It's an honor to have you join us from Australia.
It's a pleasure to be here today. Thanks so much for your introduction.
Thank you. And on our panel is Dr. Bona Mokosha Chita from Zambia. He holds a PhD in economics and he obtained his training in health economics and public health from the Harvard School of Public Health. He's currently a senior lecturer and in the Department of Economics at the University of Zambia, Lusaka. His teaching areas are focused on healthcare financing, health systems, policy, macroeconomics, research methods in economics, and health economics. Thank you, Dr. Bona, for joining us today from Zambia.
Thank you very much. It's a pleasure to be here. Look forward to it.
Thank you. And last but not the least is Professor Elvis Enobeyang Takang. Professor Elvis Enobeyang Takang is an associate professor of public health promotion and the head of Department of Population and Behavioral Sciences at the School of Public Health, University of Health and Allied Sciences. He holds a PhD in health sciences, social and behavioral aspects of HIV and AIDS and health promotion. I was in 2009 from the University of South Africa. He founded the Healthcare Diagnostic Clinic, that's the L Diagnostic, a medical center for clinical diagnostics in Kumba in 1999, and was the director and CEO of the HIV, AIDS and Prevention Research Network, Cameroon. And Professor Elvis, his areas of interest are focused on social and behavioral aspects of HIV and AIDS, public health, and policy development, and also adolescent, sexual, and reproductive health. It's a great pleasure to have you on our panel, Professor Takang.
So much. It's my pleasure as well.
Yeah. Thank you very much. So, ladies and gentlemen, feel free to drop your questions in the Q&A box. And if you have contributions to make, you can drop it in the chat box. We'll be glad to have your questions, have to post your questions to the moderator after a discussion with them. So right away, we all know that COVID-19 overwhelmed health systems developed and developing nations alike. And Africa has one of the weakest health systems globally, but there is limited evidence on how regions is how the region is impacted by and responded to the pandemic. I would like to find out from you, Dr. Tesama. I read your article with so much interest, and I would like to have just your general take on this impact of COVID-19 on healthcare systems in Africa since its outbreak in 2020. Over to you, Dr. Tesama.
Okay, thanks again, Kawu. It is really a great pleasure to be here today, and thanks for your nice question. So as you all know, COVID-19 became an unprecedented event in this time period, and as of today, it has led to over 500 million cases, and with over 6.4 million cases worldwide, of which there are over 100,000 mortality in Africa. And as the World Bank described it, COVID-19 led to a double shock, which is a health shock and an economic shock. And the health shock is it's very huge. So as it has led to several catastrophes everywhere in the world, and because of the limited healthcare system in Africa, as expected, there was a big challenge. And yes, especially earlier in the pandemic, there was limited assessment, but just looking into the experiences of early scenarios in the last 2 years, we have done a kind of evaluation, and we found out that there was significant impact already. So most of the issues we have found out included there was limited surgical capacity, which means the concomitant expansion of health services with regard to the infection rate was not parallel, and essentially most essential health services were affected in many countries. This is partly attributed to the COVID prevention strategies. There were significant lockdowns. this prevented women and children to access essential health services. As a result, there were reductions of antenatal care services, fertility delivery, contraceptive uptake were severely impacted. And in some countries, for example, in Kenya, those sexual and reproductive health services were not provided, as health services were deployed just to focus or to render COVID-related services. So these essential services were affected, and we were also observing cases from Rwanda and other African countries where there were possibilities where individuals missed routine clinical appointments. As a result, people were not able to collect their antiretroviral treatment drugs, hypertensive drugs, and so on. And the rate of hospitalization was also diminished, partly because people fear the possibility of COVID acquisition. And another impact that was observed were also around the healthcare providers, because they are at the front line. There were mental health issues for some healthcare workers as a result of fear of the acquisition of the infection, and in other scenarios, they were also not well protected because of lack of protection modalities, and they had to work hard and to three shifts continuously. As a result, this led to a lot of stress. So there are a couple of issues that we have observed. Thanks so much.
Thank you very much, Dr. Tsama, for that wonderful contribution. It really makes us to have a picture or an overview of how COVID-19 has actually affected the healthcare system. You made mention of the fact that there are reinfections, and this is really a call for concern that all countries should really pay much attention to. I would like to hear from Dr. Bona. What is your general take about the impact of COVID-19 on healthcare systems, given that the systems were already weak before the pandemic came into place?
Thank you. There's a little, what's the time limit on it? May I just take the discussion, picking up a little bit on what has been very nicely laid out, and
yes.
By way of summary, I think we know. I think everybody is fairly aware, whether you health worker, health expert, or not, or just ordinary member of the public, that the effects which have been pretty apparent arise out of the fact that we can immediately point to sort of the functions of the health system. But a little bit on the more acute side of issues, hospitalization and curative functions. Because of the nature of the pandemic, it's pandemic, epidemic, and the exponential infections, or the exponential rate in the infection rate and the sick, as well as the mortality effects. The immediate impact was to, significantly affect hospitalization. But alongside that, so again, the more traditional issues or functions or services. And here perhaps we should consider ourselves a little bit fortunate, although at the peak of it, that wasn't the case, that it's an infectious disease, and primary health care is something that we should have addressed, but unfortunately we haven't. Have developed our primary healthcare system so that the entire healthcare system, in terms of the interconnectedness of the various components, the referral systems, the logistics response systems, commodities, and overall epidemic preparedness are become part and parcel of how our health systems function. Unfortunately, as I said, we did not, and as usual, we tend to want to learn things or relearn things the hard way and the harder way. So the effect in terms of prevention, promotion, rehabilitation, we saw that COVID, even if the recovery rates were there, in some cases there was rehabilitation needed. So the commodities and the other inputs such as human resource, availability of oxygen, respiratory, everything, not to mention the vaccines, of course, and our lack of capacity in trying to develop even basics, you know, other than countries like Cuba in terms of developing countries. All these magnified are already, as you've been emphasizing, fragmented and weak nature of our health system. So this aggravated it. And unfortunately, our overall resource mobilization capacities, not that they're limited, but they're hampered sometimes by the fact that we have undeveloped institutions to optimize the resource mobilization efforts. Cameroon had one of the highest infection rates in Africa, unfortunately. But then we saw that apart from that, the issue of grants and international support, as well as local, I mean, there was tremendous effort on local institutions, local firms, local individuals to supplement government efforts. Yet, because of weak systems, accountability, lack of absorption rate, we have virtually every country from south to north has ended up with a lack of adequate accountability for how resources have been utilized, and therefore clearly indicating how we either have wasted resources or have failed to put those resources, if not directly to the COVID response, but to the health system's response in order to strengthen it. So we have had a severity in terms of the impact on financing. We've seen that it's not quite because we don't have the resources that we cannot develop our health systems, that we cannot have appropriate presence of commodities and of resources to support the availability, the distribution of human resource, for example, most important input into the whole response. But it's also part of our lack of ignoring those lessons that we've known for years we need to do. In some cases, okay, others it may be just that the health system has never been a priority, other than maybe when there are elections, a priority sector. And so trying to take appropriate planning, appropriate priority setting processes and systems has not quite been done. But whatever the case, faced with the pandemic and its demands, we've found ourselves under-resourced, unprepared, and not capable of immediately thinking of alternatives other than going out to, well, beg for resources from the international community, from the domestic local scene, from the firms, companies, and other individuals that And it has not helped our cause in terms of the overall, unfortunately, health financing strategy and response policies, in the way that, given the slowdown and stability in COVID, we've tried to move on with business as usual. There are countries like Southern Africa which have got high prevalence of or incidences of, let's say, HIV/AIDS, malaria, and you are struggling to cope with this, and you're already dependent on other stakeholders to support you. And yet you don't want to rationalize at the global level, national level, how resources are used, and also how, in particular, you support the health system. The other aspect we brought in, unfortunately, we like to experiment and to experiment with inefficient, costly institutional issues, such as, for example, social health insurance system. I think, again, this is a lesson to say, look, do the things that work best. For example, tax-based financing. Let go of these expensive experiments and rationalize your healthcare financing to optimize. All right, I'll pause there. Thank you.
Thank you very much, Dr. Bona. You've made a very interesting point there about healthcare financing. And I will come back to you regarding that aspect, because I see that currently Zambia it's working on its universal health coverage policy, which I'll come back to you for you to elaborate on that. So I would like to find out, Professor Takan, health systems constitute the foundation of achieving a third sustainable development goal of ensuring health for all at all ages by the year 2030. And health systems refers to activities whose primary purpose is to promote, restore, and maintain health systems. Can we say that the current health systems in Cameroon, for example, where we are, it's really able to promote and restore and maintain health in this area where we are? Professor Takan?
Yeah, thank you so much for giving me the floor. I will just add a little to what Dr. Bona said. You see, in our healthcare system, we adopt the fire brigade approach. But if we focus on the primary healthcare, as Dr. Bona said, and also on health promotion activities, we realize that the pressure we put on our secondary care will be minimal. Now, for a robust health system to impact the population, we must make sure that there are certain things in place. First of all, adequate financing. So I will set the scene in my discussion by looking at the WHO building blocks for efficient healthcare functioning. So if you look at the WHO model, we have six different components of an effective or efficient health system, which are the service delivery. Then we have the health workforce, the health information system, which is key, and access to essential drugs, medicine, financing, and then leadership and governance. Out of these six, financing is care. Financing is very important. Financing is leadership. Financing also impacts on the health workforce. But if you look at our health system already had some challenges before COVID came, because majority of the health funds are from donor agencies. You have Global Fund and what have you. And then in Cameroon, you realize that about 70% of the population practice this out-of-pocket payment for their health services. That's not the way to go. I remember in the year 2000, Cameroon was a signatory in the Abuja 15 Declaration, where the heads of state of the member nations of the Organization of African Unity met in Abuja, and they came out with a resolution that 15% of the annual budget should be dedicated to health. But when I check from 2001 up to date, the percentage of Cameroon budget to health, I don't think it's even up to 10%. So that is a challenge in terms of healthcare financing. So just like Dr. Bona said, we have to start looking at other sources of financing, especially the National Health Insurance Scheme. I think that's a way to go, and I don't think Cameroon has actually embraced that in totality. Then, if we look at the issue of the health workforce, COVID-19 came to expose us in the sense that we didn't have skilled health workers. In terms of quantity, they were not there. So you realize that the health workers who were in charge of other services like attending to non-communicable diseases and other diseases were redeployed to work in the area of COVID. So that which means the impact is that the other services will suffer. So Cameroon is lacking in that. And then in terms of the health information system, I don't think we have a robust and adequate health information system because, mind you, it is a health information system that drives the policy of the government. Now, I used to ask people, during electioneering and campaign, you see people come campaigning. So I asked the electorate, what informs your choice of the person you vote in office? Is it their manifesto on health? Because we must take interest in our elections. We decide those who are there, and we should look at their manifesto on health, because that will inform their policy decision that they take with respect to health. So, based on that, I don't think this is not the last epidemic that we're going to have. More are coming, and I don't think Cameroon as a system is ready to face the challenges that will present themselves in the case of other pandemics, even the COVID that is still with us as at now. So the way to go to me is looking at other areas, especially the National Health Insurance Scheme. Then we also have the issue of governance. We realize that lack of political will, corruption in the health system, and poor resource management, which all lead to weak health system, is part of us in our country. I don't want to talk about the COVID gate and other things. So for now, I will rest my case, and then when you give me the floor next, then I'll have to expatiate on some of these things. Thank you.
Okay. Thank you very much, Dr. Takam, for really making us to understand where Cameroon is and the challenges they're really facing in financing healthcare. And you really emphasize on the aspect of the National Health Insurance Scheme, which it's not really working well in Cameroon. And I would like to come to Dr. Bona, which he talked about this insurance scheme, and it's really interesting to understand, because in Cameroon, there is this huge inequality that exists when it comes to financing healthcare from out-of-pocket expenditure. A majority is from out-of-pocket, and Professor Takam made us understand that 70% of Cameroonians, healthcare users in Cameroon, 70% of them spend out of their pockets. So I would like to find out from Dr. Bona, would you recommend the implementation of the current universal health coverage policy of Zambia to Cameroon to reduce the socioeconomic inequality in spending, particularly at health centers and for curative care. Because right now, Zambia is working on implementing UHC, that's the universal health coverage for its citizens, to diminish the burden of accessing a life-saving treatment. And at the moment, Zambia is the government runs the health facilities that it offers free care at the level of the health facilities offers this free care. And Dr. Bona, is this a policy that is working in Zambia? And is this something that you can propose to the Cameroonians?
Thank you. Universal healthcare coverage, which we have all embraced. I think most countries in Africa, perhaps not all, but at least in terms of the policies, policy expressions, strategies of the national health systems at the national level. The practice that, so the policy issue has been one thing. The application, the policy part has been another. Yeah, and looking at the Cameroonian experience, we see that the share of household expenditure out of total expenditure is around 70% plus, meaning quite a heavy burden falls, expenditure incidence falls on the household. And it's clearly not sustainable from the access equity point of view, and certainly defeats the intent to try and expedite any semblance of trying to shift towards universal health coverage. We know it's a long way to go, but then if we place constraints that make it even harder, we are impoverishing our people because catastrophic health expenditures do arise and households are forced to spend resources and fall further into poverty and that type of thing. The experience of Zambia has, well, from the policy point of view, it's what we could hope for, that we have free, which was declared in 2006, between 2006 and 2010. We always had free care for under 5, over 65, and maternal health. However, health services were made free in the rural areas at primary healthcare level, which is essentially the health centers and the district hospitals, to define it in more specific context, Zambian context. And then by 2010, this was scaled up to the entire country, both urban and rural areas. We know that in practice, it doesn't work that smoothly. Health workers may exercise some innovativeness in perpetuating some form of out-of-pocket payments. And then there's the more serious issue of infrastructure, drug availability, healthcare presence, which either make such declarations meaningful or less so meaningful, because half the time, 3/4 of the time, the public are being given prescriptions, being asked to buy medicines, being asked to do laboratory tests elsewhere. It's a little bit fine, not that it's fine for urban areas, but it's so much worse for rural areas because you don't have drugstores, you hardly have any laboratories, you have to have the referral system transporting blood samples and so on, getting them lost and that type of thing. But at least the declaration were made and they were put to effect. So when the resources that matter according to the quality perceptions of the people, human resource and drugs, are available, it works well and there's less complaint, but that's not so smooth. So it is certainly the beginning of the effort towards universal health coverage. And what do we mean by universal health coverage? Very simply, we're trying to get at least a minimum of 90% of our population have access to healthcare without any financial limitations or constraints being imposed on them. So they are not going to the health center because they can't afford, either because of transport, which means the distance matters, where the facilities are, where the health workers are, the payment matters, either the government subsidizes or there are waivers such as saying, okay, this is free, but for secondary, or if you bypass the referral system from first point of entry to the next, then you pay. So to try and discourage sort of moral hazard issues on the part of consumers. So I would suggest that although this is not saying this is a Zambian solution, but there's certain attributes or factors which enhance each country's drive towards universal health coverage. Cost is one of them. If we can eliminate that or subsidize it, minimize it, and to do that effectively, there's just no way it can be done without government intervention. So the government, I know there are these excuses about resource constraints and there are other things to do. It's a question of priority setting. And with appropriate resource allocation, these things are attainable for any African government, I believe. So trying to use tax resources, in my view, rather than, I think you had a little bit of difference. I am a little bit against this social health insurance scheme because of its cost, because the lessons are showing us right now that the long-term effects of social health insurance are to increase the transaction cost, the cost of providing healthcare, as opposed to the short-term, to the tax-based financing. Where do we get this evidence? If we look at the so-called beverage models, which are England, Sweden, New Zealand, a little bit of Canada, these countries, we see that they are tax-based. Their performance indicators and outcomes continue to be some of the best, if not better. When you look at these countries with social health insurance, the Germans, the France, Netherlands, and so on, they're beginning to suffer and debate right now how they can sustain social health insurance or whether they should have it. Of course, we know the factors underlying this are coming from old age care and so on and so forth, technology increases, but that's the nature of the financing modality. So I think when I look at Cameroon, I look at the structure of the healthcare financing, or look at South Africa or Kenya, and then I see these types of indicators and data which work towards against equity, fairness of the health system, exposure to financial risk. I think they need to step back and consider these alternatives of subsidizing healthcare, maybe not making it free, but substantially subsidizing and increasing. I mean, we've just been debating here that the lessons of COVID are that we must learn to strengthen our health system, and we must learn to make access to healthcare services better. Otherwise, there's nothing we have learned, and we'll keep going around in circles. The developed countries are not going to come. I mean, we've seen the politics around COVID vaccines. Nobody was thinking of Africa. So I think it's time to say we need to do what we can and improve our responses. Thank you.
Thank you so much, Dr. Bona, for that wonderful contribution. And you've made us to understand that it's very important that the government really subsidize access to healthcare services, and it's very expensive, especially in the rural areas. This is very useful, and this is very important. I would like to find out from Dr. Tesama, what is your take on the out-of-pocket expenditure in this COVID area? We already understand that the COVID-19 has come, it has really weakened the healthcare system. Before, we pay huge amounts of money to access healthcare services. And with the presence of the COVID-19, healthcare financing, it's really terrible right now in different African countries. So what do you think about the out-of-pocket expenditure on Africans?
Yeah, it's really a very interesting point. I heard what Dr. Bona said. It's very interesting. So it just reminded me the fact that in many African countries, out-of-pocket expenditure is one of the sources to support the health services. I was looking into data. Few African countries like South Africa, 6%, and Rwanda around 10–15%. Otherwise, in most other countries, out-of-pocket expenditure is very high. And in the era of COVID, it means that because most of the services, especially when people want to get, some advanced services and long hospitalizations because of COVID, the out-of-pocket expenditure will be catastrophic for this individual, and it will be a big, it will have a big impact for the community, for the family, and at the same time, there was a lockdown. What does lockdown mean? If there is a huge lockdown, people are not accessing health service, which in return means health facilities are not generating money to be able to use to pay for their health workers, to procure necessary equipment, and so on. So the reduction or the drop in facility visits and so on means that the out-of-pocket expenditure is also diminishing. That's why, especially in the era of universal healthcare, other models like community-based health insurance models, there is some beginning in rural areas in Ethiopia and in other countries as well. And there are public sector model where tax money are directly being used to build the health system. I know the country where I'm living, Australia, is not a good model for Africa, but the government is, funding everyone's expenditure, and there's no problem irrespective of your socio-economic status. You can have your health services covered, but it's not easy to do something in Africa, but feasible models and strategies need to be built. And the other issue is most of the services are also donor dependent in addition to the out-of-pocket services. So in such pandemics means the focus will be changing, and donor countries have also their own priorities, and they need to focus in research and other areas. This definitely harm existing services. For example, some of the essential services like HIV, tuberculosis, malaria receives, donor support significantly, but in the era of COVID, the contribution would be diminished, and it affects the essential health service provision in these areas. I just want to add this point, otherwise it's all good.
Yes, thank you very much, Dr. Tesama. It's very important and for us to know how this pandemic has really affected out-of-pocket expenditure. And that's what we are trying to see, what the government can do in order to rectify the situation or ameliorate the situation in such a way that everyone everywhere can have access to healthcare services without suffering financially. I would like to find out, Professor Takam, you are an expert in HIV care, social and adolescent sexual and reproductive health. And you founded your organization in 1999. Let's look at it specifically. Professor Dr. Bona made us to understand that Africa is learning the hard way, because the pandemic has made us to understand that we are learning by the hard way, and we have not made healthcare our priority. I want you to look at HIV specifically, like how has this pandemic really affected the HIV and care program in Cameroon? Dr. Tessama made us to understand that this pandemic has, affected the care, the management of HIV and AIDS. From your point of view, what do you think? How has this pandemic affected HIV care in Cameroon and prevention too?
Oh, thank you so much for this is a very important question. It has affected Cameroon. It has hit Cameroon so hard. You see, the funds to fight HIV in Cameroon is mostly from the Global Fund, but there's a counterpart funding that Cameroon has to provide. If speaking from the hair promotion lens, you realize that if you apply the 5 key areas of the Ottawa Charter for Hair Promotion, from healthy public policy to creating a supportive environment and strengthening the community action, developing personal skills and reorienting the health services, you realize that all these 5 key areas were, in terms with regard to HIV/AIDS, were actually affected by the COVID pandemic. I recall about some few months back, we had patients on dialysis on the street. That was the effect of COVID, because the government attention was on COVID. So actually, funds and resources that were supposed to be targeting other areas were channeled to the COVID response. Now, in terms of the HIV care, what the people on dialysis suffered, I was expecting that also to trickle down to HIV patients, but that didn't happen. I don't think it will happen. But in terms of the care for HIV patients, we realize that there's a department or direction of hair promotion in the Ministry of Health, but I don't think they are doing enough. Like, I wrote a paper last year where I actually highlighted the issues that the fight against COVID will actually interfere with the continued management of HIV patients, in terms of, we had a lockdown. And then other staff who were actually attending to HIV patients were redeployed to the COVID response. So I was actually wondering what happens during the lockdown, where patients used to come on monthly basis for ART refill. What will happen if care is not taken? Such patients will develop resistance due to non-adherence. Because of the lockdown, we're finding it difficult to come for their HIV refill every month. So I propose that maybe they should be given drug on a 3-month or 6-month basis. Or the non-governmental organizations and other community service organizations working in the field could be strengthened with a capacity to meet or reach those HIV patients in the community, to take care of them. I have not actually done any finding to actually ensure if that was the case or not, but that's what I recommended in my paper last year. But by and large, I think the response, the COVID response, the fire brigade pattern that the Cameroon used affected many sectors, including HIV. Yeah, so I think no other sector should be neglected because of COVID. Though this is not the last pandemic we're going to get, but we should learn from this to strengthen our health system in terms of adequate financing, in terms of the workforce, in terms of good governance. And mind you, Cameroon has 5 levels of healthcare. We have the community where we have the health post. Then we have the sub-district. At the sub-district level, we have the health centers. At the district level, we have the district hospitals, the secondary care at the regional level, and then the nationally, we have the tertiary care. So going by the Health for All, which was established in 1977, and then in 1978, we came with the Alma Ata, the primary health care as a way of ensuring health for all. We should focus on all the levels of healthcare, including the community level, and meet the people there at the community if we are actually aiming at attaining the universal health coverage by 2030. So that's my little contribution with respect to that. Yeah.
Thank you very much, Professor Takam, for making us to understand the impact of this pandemic on HIV care. And this is a serious issue when it comes to preventing, controlling this pandemic. Professor Bona really hit hard on the fact that Africa is learning the hard way. It's learning the hard way, and we don't want Africa to learn the hard way anymore. This pandemic has really taught us a great lesson, which we don't want it to repeat itself. I would like to find out from Dr. Bona, from your economic perspective, is there something apart from this pandemic we should pay attention to in order to prevent any unforeseen circumstances when it comes to financing healthcare?
I don't think really there's anything new which we can say we've really not, has not been brought into the domain, the public health domain, that we need to address. But with respect to your question, I think the issues or the questions we should be trying to answer may relate to what are the prerequisites of ensuring our ability to strengthen our health systems into an integrated, coordinated whole. That eliminates fragmentation so that the private sector does not just cater for the urban well-off and provide resources tailored to those that have money. The public sector does not cater and get lost in lacking any sense of priority setting and trying to set up cancer hospitals, for example, and providing services into these high-end conditions which afflict only a minority of the population. I think we need to go back and say, well, what happened to our essential healthcare packages? What happened to objective analysis and evidence base of matching resources with epidemiology, such that that balance automatically factors in issues of fairness, equity, and at the same time, where's this evidence base or capacity that we are ignoring in terms of how we can maximize our procedures, interventions, and programs in terms of cost effectiveness? These are things that we know, but which we totally ignore. I think that's part of the reorientation that African health systems need to make. Of course, there are other things that I could go on, but I would like to perhaps highlight those.
Thank you very much, Dr. Bona. It's very important that we look at what is the essential healthcare package. We look at equity, fairness, and a lot of reorientation needs to really take place to really ameliorate the healthcare system. Dr. Tessama, what is your take on this?
Yeah, thanks again. This is a really a nice question. So yeah, so COVID-19 gave us, a good lesson on what areas we need to strengthen our service. So one of the important area I believe is research capacity needs to be strengthened. So even earlier in the pandemic, there were a lot of speculation COVID lead to this and that, but there was no much research exploring or sharing experiences in several countries. So research needs to be a focus to map the available evidence and to redesign, the existing health service to tailor what's needed based on the available evidence. The other important issue, I believe, is the human resource development should be another focus. In our study, what we also observed was in some setting, although there were equipment, let's say ICU materials, there were no workforce who can manipulate this material. So there was, $1 million machine that no one was able to manipulate. So it's essential workforce training should be there, and increasing surveillance activity should be strengthened. And we have also observed that there were a significant, misconceptions and a lot of rumors. Such information were disseminated across the community widely. So there is a communication addressing this misconception need to be there. And I know it is still underdeveloped in Africa, but services that involve telehealth, mobile health need to be strengthened, need to be planned in the future, and especially in circumstances like COVID-19, there will be much important. I think we should think of things like this in advance, so we can use the available services, the existing services, and that can be more useful in such circumstances, I believe.
Thank you very much, Dr. Tessama, for that contribution. It's important we look at research capacity and also the human resources, which is very, very, very important. Thank you very much. Professor Takang, we have looked at the National Health Insurance Scheme, but what would you say about the private health insurance in this area where the healthcare financing is really crawling on its knees? What would you say? What can the private health insurance companies really contribute? What can they really do to improve on healthcare financing in Cameroon?
You see, the issue of healthcare delivery, we are looking at bridging the equity gap, providing health for all at all ages. Means healthcare should, the cost of accessing healthcare should not be a challenge. So if we bring in the private insurance companies, if the government can partner with them in such a way that we're going to reduce the out-of-pocket payment that the patients or those accessing healthcare are providing, I think it's a way to go. But if it will be at the detriment of those accessing healthcare, then we should look at it again. But all of this depend on government policies. It's policies that drive all of this. Looking at the universal health coverage, the government has to provide funding. But if they will do that in partnership with the private health insurance, then that is fine. I think that's the way to go. The whole essence is to reduce the out-of-pocket payment that those accessing healthcare are making for their healthcare. I think it's fine. But in all, the government should drive the process in terms of policies and in terms of ensuring that the policies are adhered to, and in making sure that the citizens or the population don't have to pay much. They can pay something little. Like what we do in Ghana here, I work in Ghana, so what we do is that we have this National Health Insurance Agency. If you are a government employee and that you are contributing to your social insurance scheme or your pension scheme, you just pay a token. If you convert what you pay annually, it's not up to in France CFA, it's not up to 2,000. But with that, you are enrolled into the scheme, and you are issued a card, like an identification card. You take it to any health provider. If you have issues, health providers are subscribed into the scheme. You are taken care of on common ailments. And I've benefited a lot from that. Even I have colleagues who have done eye surgery and they pay barely nothing. You convert it about 2,000, 3,000 francs CFA. So I think that's the way to go. If the government can partner with the private insurance and provide some incentives or support, so that the population shouldn't be paying from their pocket, I think it's a welcome development.
Thank you. Partnership with private health insurance is the way forward. This is a very important contribution that can help us reduce out-of-pocket expenditure. Dr. Bona, would you agree? What's your take about private health insurance, and should the government really partner with private health insurance companies? Or are there other measures the government can take?
Partnerships are good, particularly in health, and especially at community level, perhaps to build up that social capital that enhances, to some extent, attainment of positive or improvement in positive health outcomes. But the private health insurance is something that is dependent on the ability to pay, willingness therefore to pay on the part of an individual or a household. It's equity implications from that point of view may tend to be more regressive, tending to support the tending to favor those that have more wealth than others, and some may say, well, ethically there's nothing wrong with that, and I think to that extent there would be perfectly right. But then where there may be ethical issues is then if the state is going to partner, what ways would they partner with those institutions that are set up to cater for the provision of health services to the affluent? And therein would come some ethical dilemma on the part of the state. When there are hundreds, thousands of children, pregnant women, old men in need of those state resources. So perhaps it may be worth considering that those that have the money, the wealth, and they certainly can afford private health insurance. And that it does, I mean, look at South Africa and their own private health insurance. I mean, you have, well, for historical reasons, we know what goes on and why the structure, the setup is like that. But, well, the whites were coming from this background. And so the role of private health insurance dominates, and it dominates amongst a certain racial group for obvious reasons. So the state in that case may not have much role or should not have a role, and should focus, as the South African government did, in providing health services to those that are outside the coverage. And that's where they need to build the partnerships, I guess, to try and say, okay, this is what's happening, so how do we, you are focusing on the affluent. Of course, there's that question of cost inflation, medical inflation, and private insurance, as well as people's behavior. But again, we're saying they're paying for it, they can afford it. But there's need for regulation, perhaps, because the cost pressures from private health insurance may affect what's happening in the public sector. So perhaps there's need for that control. But otherwise, perhaps we need to consider that private health insurance may be the least of the concerns, given the enormity of other problems that African health systems have to contend with.
Thank you very much, Dr. Bona. It's very important to, like you said, what are the regulations behind the partnership? How should the partnership be done? And it's important for regulation. There's need for that regulation. And I was really thinking, like, with the perception of Africans about private insurance, about what they think about the private insurance. Is it something we should be concerned about? Like, sometimes they say, no, the private health insurance, it's a scam. It will not work. If I go to ask for my money, they won't give it. They know they say it's very complicated. So is it something we should really pay attention to, especially in this COVID era where health out-of-pocket expenditure it's high? Dr. Tesama, can you?
Yeah, so would you please repeat your question? Sorry.
Okay, I was asking, like, the issue of the perception of Africans about private health insurance. You know, sometimes say it's not working in Africa. It works well in in the developed world. It doesn't work in Africa. So is this something we should be concerned about in this era where we want to reduce out-of-pocket expenditure?
Yeah, that's a nice question. So, yeah, in Western world, for example, in a country where I live, there is private insurance, but this is on top of the public insurance. For everyone, there's a government health insurance, which they call Medicare, which covers most of the basic services, but you can still get private health insurance to cover, additional services that the public funding would not cover. In Africa, yeah, it's still a difficult question, but it will probably target, middle high income, those who will be able to contribute. That can be beneficial, but for attaining universal health care just to provide health services to the disadvantaged community, to rural, to the majority of the poor community. Probably other approach like the community-based health insurance and the public funding could be important. And in some instances, there could be like co-payment approach where individuals get, services from the government and they can pay out of pocket, for example, for medicine or for some of other things. It's some kind of integration approach can be used in community-based health insurance is kind of being advocated in many other countries, and that can be evaluated if there is something that can be adapted to Cameroon. That would be a good approach. There are experiences anyway, including in Ethiopia, Tanzania, where community health insurance is being provided, and the lessons can be drawn from this country.
Okay. Thank you very much, Dr. Tesama. It goes again to what Dr. Bona said, that subsidies is very important to finance healthcare. And the fact that those who are not in the coverage, those who are not covered by health insurance, the government can partner with, can see how they can finance healthcare for those who are outside the coverage. Ladies and gentlemen, we are talking about the impact of COVID-19 on healthcare financing in Cameroon. And we would love to have your questions. If you have any questions, please drop it in the chat box and we will gladly ask your questions to the experts we have here on our panel. And we have a question. This is to Professor Takan. Participant is asking that despite the fact that that's in 2001, where the African countries agreed to spend 15% of their budget on healthcare financing, but up to today, very few countries have really tried to attain 15%. So what could be, what's your proposal? How can we raise up our budget to 15%, given that we were part of the signatory in 2001 in Abuja?
That's a very good question. You see, treaties that are ratified by a country, they don't force you to do it. But once you ratify it, it's incumbent on you to apply. And it becomes a policy. And there's a way that you can actually change or cause the government to change a policy. It's advocacy, which is also part of health promotion. So health promotion is an area, to me, the backbone of public health. And unfortunately, Cameroon has not actually embraced it. Like the status of health promotion, which advocacy is key. And it's only by advocacy that a policy can be changed or brought to bear. So Cameroon is not doing that. It's not an issue of raising funds. The funds are there. It's just a matter of funds allocation. Allocate 15% to health. That is it. And we must move from this secondary care of fire brigade. If you are sick, you go for restoration. No, we are saying that once you reorient the health services to primary health care and health promoting activities, we are not saying that people will not be sick, but you might not, the government will not be spending a lot of money on high-tech equipment, which are very expensive to buy and very expensive to maintain as well. So if they are not adhering to the 15%, we should advocate. We have advocacy groups, they can do that to make sure the government does that. So that's all.
Okay. Professor Takan is talking about advocacy. That is what we should be focused on in such a way that we can increase our health spending to 15%. This is a question to Dr. Bona. You talked about the use of tax resources to finance healthcare. And a participant is asking that, is this not a strategy? Is this not an indirect way of taking money from us to still pay for the healthcare services? Dr. Bona?
There's only one sure thing, as it's tax and death, of course. But they are. What are the options? I think this is the context, isn't it, that we are debating this? What are the options? And of these options, what may be the strengths of some of them that are stronger or put others in a slightly better position for attaining those objectives? What are those objectives we like? We like overall improved health status of the population. And then we have process indicators such as coverage and so on. If those are the things that we are pursuing, then if we don't use tax, what else do we use? And what is the effect of those alternatives in terms of the accomplishment of our health system's outcome or goals? I think that is the kind of integrated approach that we need to take when we're considering these financing options. If, for instance, it's out of pocket, as we've seen and we know, Cameroon, for example, has one of the highest out-of-pocket expenditures. And is that a bad thing or it's a good thing? Well, when you look at the share, I mean, if a household is spending almost over 50% of healthcare expenditures on out of pocket, that's huge, and it's undesirable. Why? Because firstly, poor healthcare services. Secondly, households cannot afford it. So that there's so many negatives already with out-of-pocket cost sharing, full cost recovery, private sector. So what about social health insurance? Well, it is slightly better because it's a pooling system. It allows, probably does, will allow strategic purchasing, which enhances provision of health services or accountability and transparency in providing health services. But again, because of the limitation of coverage, formal sector employees may be what? 20%, 10% of the entire population. And in the meantime, you are using public resources to provide an equitably and fairly services at the exclusion of the many. Again, ethical questions, and you will not in any case sustain that. You end up probably having to subsidize because the public sector contributions will be so limited, and they will be hostile towards their resources finding services for the entire population. So with all these drawbacks, I mean, I'm summarizing things because of time, then you're left with tax-based financing. The beauty about tax is that you can make it progressive. Those that earn more, tax them more. Those that need more healthcare, spend more to provide it to them, so long it's not on cancer or obesity-induced diseases because they don't care what they eat, and so on, you know. But at least rationally, which is why I talked about essential healthcare packages, that there is a system that we use to prioritize and then can use resources to be allocated in a logical, sequential, and rational manner. So no, taxation is a better evil than the other alternatives of trying to raise revenue.
Thank you, Bona, for that wonderful analysis. It really makes sense, and I think our audience is satisfied with that response. And there is a contribution. Somebody agree with you, Dr. Bona, that Africa really needs to prioritize healthcare, not the politics. We should not focus more like what Professor Dakan said. We should not be too focused on the politics aspect, but make healthcare a priority. And we have signed the Abuja Declaration. We should try to stick to it. Another contribution is for Dr. Tesama, who says, thank you very much, Dr. Tesama. It's true, we need to prioritize healthcare to avoid re-emerging diseases. Thank you very much, dear panelists. We are almost drawing to the end of our discussion. And in just 2 minutes, I will just find out from you concretely, which policy recommendations would you recommend in this COVID area? What are the policy recommendations that we can recommend to policymakers so that healthcare financing can be ameliorated? Dr. Tesama, would you go first?
Yeah, okay. Yeah, so again, this was really a nice and engaging experience. I have also learned it from other panels. So my remarking point would be around the fact that we need a resilient health system. We have been dealt with what a health system means. Health system has its own building block, starting from the delivery of health services, human resource, information, healthcare financing, leadership, and so on. This all should go hand in hand to provide a resilient healthcare system. So a resilient healthcare system is something that can be able to adapt to a shock in the form of pandemic or any other catastrophic, and at the same time it also allows you to quickly recover and stand by yourself to prevent future pandemics. So previously we have been dealt a lot about COVID, and it's only 4 days the Director General of the World Health Organization declared that monkeypox is becoming a global concern, right? So this indicates that emerging diseases will continue to be a problem for the globe. So this needs to be a focus in establishing and building a resilient healthcare system, active surveillance, and so on. So that's my take.
All right, thank you very much, Dr. Tesama. Professor Takan, any recommendations from you on how we can improve on healthcare financing?
Yeah, the only recommendation I will give to the government is to look at the WHO building blocks for health system or healthcare delivery, and make sure they adhere to all. But financing is part of it. Without financing, you will not have adequate system delivery. You will not be able to train the health workforce to prepare them for any eventualities or emergencies. And you have to make sure the entire population has access to essential drugs. Without financing, all this cannot happen. So adequate financing is very fundamental to effective healthcare delivery, and it will also help in attaining the universal health coverage. Then apart from that, the government must look within to generate funds instead of depending a lot on external funding. So to me, these are my recommendations. And beyond all, the issue of an insurance scheme or anything that will ensure that everybody has access to healthcare with minimal expenditure. So that's my take.
Thank you very much, Professor Takan. Your response matches the question we have in our Q&A box, which says, knowing the way in which the Cameroon government functions and the lack of prioritization that has been placed on healthcare financing, is attaining universal health coverage really feasible? So I think this the building blocks you've talked about from the WHO really answers the question of this participant. Thank you very much for that contribution. Dr. Bona, any last words from you on how we can improve on healthcare financing.
It will help if our policymakers can appreciate that the care for their population's health is first and foremost the reason they get voted into offices. And it is not the responsibility of the international community. Look at Cuba, right? And I think Cuba answers how we should try and prioritize, place, and replicate lessons of healthcare financing, service delivery in African context. Thanks. Thank you.
Thank you very much, Dr. Bona, for that very, very wonderful contribution on how policymakers can improve on healthcare spending. I see Professor Takang and Dr. Desama really nodding their head, shows that we really agree and we're on the same page on how we can really ameliorate healthcare financing. Thank you very much, ladies, gentlemen. Thank you for your wonderful contribution. It has really been an exciting session, exciting discussion with you all. And thank you for taking time out of your busy schedule to share your valuable experiences with us. It's really wonderful. We look forward to organizing sessions like this. To our online audience and those who are following us live on Facebook, thank you very much for joining us. And we look forward to having you in our subsequent panel discussions like this. Thank you very much and do have a wonderful day ahead.